All right, hey guys. Essentially, this is going to be a quick revision lecture for respiratory conditions. I'm going to try focus on the high yield GP respiratory conditions and what areas you really need to know of them. That being said, um, please read up a bit on the background of these conditions separately. I'm just focusing on the exam content. Any questions, shoot me an email, shoot me a message, details down below, and let's get started. Hopefully, this isn't going to be too long. We'll see how we go. All right, asthma, huge. So, chronic obstructive inflammatory condition, main kind of thing to know in regards to the features is that it is reversible. So, when you do your lung function testing, you have an improvement with the salbutamol. Now, whereas COPD, you don't have that. Um, Three features are bronchial hyperresponsiveness, reversible airway obstruction, and increased mucus production. Now, in terms of the pathogenesis, the allergic subtype is like the main, most common one, part of your ATP triad. Now, in regards to this pathogenesis pathway, you have your T cell hyperactivity that is present. Then, when exposed to the allergen, this activates these T cells, and the T cells recruit the eosinophils and mast cells. It does this by like cytokines, IL-4 and 5, I believe. Please correct me if I'm wrong. But it, I don't think you need to know that depth, anyways. Um, Now, this consequently causes mucus hypersecretion, bronchiconstriction, edema, hypertrophy. So, this is a bit of a diagram of the pathway. All right, classification of asthma. So, you can kind of define it in regards to the actual lung function testing, being like uh, in regards to the FEV1. Or it can be more symptom based of how frequent these symptoms are. Now, also, when you're having an asthma attack itself, you have like the mild, moderate, severe kind of categories, with like mild being like can talk full sentences, up to severe, where silent chest, unresponsive, those kind of things. So, there's different ways of classifying it. More in the GP setting, it's basing it off here. Now, just important to note that like FEV1 um, over FVC ratio is dependent on your age, and I believe gender as well. So just be specific to check back with those specific groups on when looking at the lung function testing. Alrighty, what else to note from here? You can also have intermittent asthma. That's just like if you have it on and off for like less than a year. But yeah, not much else from this table that's high yield. Alrighty, in regards to the actual management of asthma itself, so you have all your different puffers. It's good to note that like the different colors are different types of whether it's like a lava or a llama or a whatever, saba. So a lot of people don't know what their puffers are called, and you just simply say, what color do you use? Like what color ones? And it's good to know if you hear the color, then you kind of know what they're taking. Alrighty. Fun fact, National Asthma Council Australian guidelines actually changed 2 weeks ago. So in mid-September, depending on when you watch this video, but mid-September 2025, they now no longer recommend SABA only as needed therapy. They recommend all asthma patients to be on an ICS, so an inhaled corticosteroid. Um, it's yeah, so no longer that kind of step one is really used. So step two is now the step one for all asthma patients. So on regular daily ICS and then a SABA reliever as needed. Um, or you can have the low dose combo down the bottom there. essentially then as you move up, adding in a longer acting beta agonist, and then moving up again to having higher doses of your ICS and LABA. Any higher, you're referring off to a specialist, like even at step four, you'd probably be getting a specialist involved, rather than a GP. So you don't need to know much about your add-on specialized treatments, just knowing when you need to refer as well. The GP exam is really also highlighting the importance of the GP knowing when you need specialist or emergency involvement. So always remembering to stick within the scope of practice of a GP clinic. Now, important to know some of your names of your SABAs, LAMAs, ICS, so that for your multiple choice answering questions, so just go through the common ones there. So they've, yeah, um, go through that in your own time. I feel like it's not going to be helpful me going through it now. In terms of acute management of asthma, so in, you want to know the rule of fours, so four puffs, four breaths for each of the puffs, and then after 4 minutes you repeat. So this is your asthma attack. This is a really good infographic to give parents. You can talk about this through your Apex Plus or whatever it's called this year. In terms of actually using a inhaler, I've got one here. You give it a shake, puff. If you haven't used it for a period of time, you want to recommend, like if it's over 2 weeks or something, recommend you have to prep it, you shake it really well, give 2 puffs to kind of clear out the system, make sure it's all nice and clean. And then when it comes to inhaling the salbutamol, the puffer, you want them to firstly take a big deep breath out, exhale all the air in their lungs, then wrap their lips around the front mouthpiece and keep your chin kind of up and high. Seal, have a nice seal, and then puff the asthma puffer and breathe in at the same time and hold for 10 seconds and then breathe normally. It is quite poorly done. So it's a really good OSCE station. And you should know how to use it, also know how to put a spacer on. That kind of makes it a lot easier rather than having that whole holding and breath kind of synchronous activity with the puffer. So yeah, that's another way to do it. Beautiful. All right, acute management of asthma. This is hopefully going to the emergency department, but it is good to have at least a basic understanding of it. Um, so OSHIPME is the acronym, great acronym for the management. So firstly, oxygen, you're wanting to aim for stats around 93, 94 still, so that oxygen drive. But yeah, so whether it may be nasal prongs, Hudson's, it really depends. In terms of salbutamol, you use the burst therapy. In the community, you're using that like rule of fours. So that's what you kind of really need to know as GP. But do know just at least the basics of the salbutamol burst therapy every like 20 minutes. And then depending on age, how many puffs and the concentration, very severe cases, you're using a continuous nebulizer, and then reassess after an hour. Hydrocortisone, it's usually pred in Oz, but for the acronym, hydrocortisone is used. If worsening, now this kind of steps you won't need to know as a GP, but they're there. COPD. So the irreversible cause of airway obstruction. So inflammation of the small airways with a mix of chronic bronchitis and emphysema. You may have been taught the pink puffers, blue bloaters. From my understanding, they don't really like separating it these days. It's usually really a combination of the two of them. So just knowing chronic bronchitis is a productive cough of at least 3 months each year for at least 2 years. Emphysema is dilation of the airway spaces caused by the destruction of the alveoli. Now, this destruction is usually due to smoking in your COPD. Classic cases in the GP clinic are your chronic smokers, that have the chronic bronchitis and emphysema picture. Classification is based off your FEV1. of the predicted value for the age and gender. And yeah, the percentages just go down, as you can see, mild, moderate, severe, very severe. Management, first line, SAMA or the SABA, then you add on a long-acting LAMA or LABA, and then you add on a steroid. You want to add on the steroids last, unlike your difference to asthma, because COPD patients are prone to infections if they're on a steroid, which is an immunosuppressant. And most, I don't want to say most, COPD patients who can pass away from having infected exacerbation of COPD. So you really don't want to compromise them anymore with an immunosuppress. So that's why the steroids are last line. But that being said, if they need them, they need them. But yeah, you're probably getting some more specialists involved there at that stage. Non-farm, really important. Also, I didn't really mention it for asthma, but yeah, for most conditions, you can kind of come up with some sort of non-farm management form. In the case of COPD, lifestyle, obviously stop smoking is ideal. Obviously extremely hard, but you can have your motivational interviewing stations on that. And just other lifestyle factors are good. Annual flu and pneumococcal vax is also really important. Pneumonia. All right, so pneumonia, obviously GP land, so typically wouldn't see hospital-acquired pneumonia. That being said, if someone discharges from hospital and they're within that 48-hour period of being discharged from hospital, they would be considered to be a hospital-acquired pneumonia case. But mostly you're going to get your CAPs, so your community-acquired. Can be broken up into typical, atypical. Atypical refers to the intrinsic resistance of these organisms to beta-lactams. So there won't be on gram stain, like the traditional techniques of gram staining to visualize the bacteria. Hopefully that makes sense. So yeah, if you're expecting someone to have your atypicals, they call it like the walking virus, I meant the walking pneumonia, then you need to do extra separate testing. There's like an atypical panel. But yeah, most of the time it is your um s s oh, sorry. Yeah, like completely. Yeah, so most of the time it's your typical bacteria as the most common cause. You can also have viral pneumonias, but yeah, won't focus on that too much. All right, so presentation on exam, dull percussion, and then auscultation, increased vocal resonance, bronchial breath sounds, buzzwordy, and coarse crackles are buzzwordy. So, and bronchial breath sounds are when like you have like the inspiration and expiration that are like matching with like the gap in between them. X-ray, you have lobar consolidation for typical and then diffuse patchy opacities for atypical. All right, some buzzwords of like the likely organism based on the history exam and findings. So I'm going to like not even pronounce these organisms because I am shocking at pronunciation. I'll try to step through some of them, but please do not judge me on my pronunciation of organisms. I do struggle. All right, so buzzwords. If you have your office workers in like the air-conditioned buildings, water towers, those types of things with pneumonia, pitcher, upset, diarrhea, hyponatremia, it's your Legionella pneumophilia. You've got your gardener who's soiling in Australia. They've got your Legionella longbeachiae. You have your alcoholic aspiration pneumonia. They have the current jelly sputum. They've got Klebsiella pneumoniae. Bird exposure, so parrots, pigeons. They've got Chlamydia pertussae. Farm workers in the abattoirs, they have your Coxella, which causes Q fever. Cystic fibrosis patients, Likely organism that they are affected with your Pseudomonas aeruginosa, and they get those recurrent infections, quite nasty. Overseas traveler, immunocompromised, weight loss. They've got mycobacterium tuberculosis. Young adults with flu-like illness, hemolytic anemia. They have mycoplasma pneumonia. HIV in individuals with HIV or are immunocompromised, who have diffuse bilateral infiltrates, ground glass appearance on X-ray. They most likely have PCP. And then your post-influenza or individuals who may potentially be IV drug users or have skin abscesses. They have Staph aureus most likely. And this is all in the background that they have a pneumonia picture, so all the signs and symptoms of a usual pneumonia. All right, management, quickly running through this. Know your curb 65, important for whether you can manage in the GP clinic or you need to send them to ED. In GP land, you're mainly prescribing amoxicillin, maybe doxy if you're expecting an atypical. But yeah, just know mild, moderate, severe, amoxicillin, mod, Ben, Pen, Doxy, and severe ceftriaxone and Zithro, and make sure they are in the emergency department for both moderate and severe. People can die really easily. All right, lung cancer, symptoms, cough hemoptysis, or your B symptoms. Imaging, send them for a chest x-ray to begin with, and then you need to progressively stage and get a better picture. Biopsies can be done. If suspected, either bronchoscopy or CT guided, depending on what the radiographer says. It's not up to you to decide. But bronchoscopy is more for, it depends on if it's like essentially a peripherally located cancer, which we'll go into which one's which, more likely. All right, management depends on the type and stage. Don't really need to know much about it. Targeted therapies can also be used. Now, what you do need to know is that there is now a prevention guideline by the National Lung Cancer Screening Program. So, as a GP, if you have a patient who is between the ages of 50 to 70, has a smoking history of 30 plus pack years, and either is a current or quit smoker, then you do a screening for them. All right. In terms of types, so non-small cell carcinoma, you got your adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. I like tables, so hopefully this gives you a nice overview of the differences, where like adeno is more peripheral, squamous central, non-smoker is more typically adeno for the non-small, and overall non-small is like a slower spread, especially the squamous. So yeah. Small cell carcinoma is rapid growth, huge on the paraneoplastic symptoms of Cushing's and SIADH. More common in smokers, it's the perihilar one. And yeah, in terms of other tumors, you can get your carcinoid and your other rare lymphomas, sarcomas in the region of the lungs and mets there as well. Acute bronchitis, so this is very classic presentation where an individual comes into the GP clinic who's feeling unwell, cough, fever, malaise, but they examine pretty well. So it's usually a viral-induced acute bronchitis picture. Supportive management is very much appropriate. Antibiotics if needed. Promote Panadol use, those kind of things. Treat the symptoms. So Panadol, those things. And just safety net them really well. Nothing much you need to do there. R2, so PE. So if you have an individual presenting with sudden onset, shortness of breath, pleuritic chest pain, cough, potentially hemoptysis, kind of rare, increase respirate, increase heart rate, then be red flag, PE. Usually it's a DVT, so always check their calves. Risk factors include immobility, surgery, cancer, pregnancy, if they're on oral contraception or HRT, obesity, thrombophobia, any other coagulation disorders, things like that. All right, investigations that you'd want to do. As a GP, definitely consider getting them to the ED department. But in general, investigations that you would do, D-dimer, very controversial. I feel like most doctors these days are just saying it is just not sensitive. So half the time you just, but yeah, it's specific. So if you're expecting it, then I would do it. ECG, most common is just sinus tachy. You have the S1Q3T3 presentation on ECG, but if it's not always there. Main thing, CTPA or VQ. Use VQ if CTPA cannot be used. Reasons for not using CTPA is if they have poor renal function or if they are pregnant. Those are very common. The other day, I actually had a patient who was allergic to the contrast in the CTPA, so they did the VQ scan instead. But yeah, treatment, anticoagulate them, plus or minus thrombolize, and supportive therapy. Just a note on supportive therapy, always consider like in your Apex Plus, OSCEs, whatever they're called these days, always consider when managing a patient, you do their supportive therapy. You have like a branch in your mind of when managing supportive therapy, this, and then treat the actual like symptoms itself. So yes, you need to anticoagulate them, but they are in pain, so give them pain relief. They might be um low stats, what's called oxygen deprived. So give them oxygen therapy as well, those types of things. This is obviously a bit more hospital based, but PE patients should be in hospital. All right, pneumothorax, another one that should be a hospital case, but it's also recognizing it in a GP clinic. So sudden pleuritic chest pain, shortness of breath, sometimes cough, unilateral decreased breath sounds on examination, hyperresonance, and decreased chest expansion, or like a not a symmetrical chest expansion. So yeah, it's essentially when you get air into the pleural space, it can be spontaneous or traumatic. So it's like classically your spontaneous ones, you're really tall, teenagers, boys, those kind of things. I think it's Marfan syndrome that has a more common presentation of pneumothorax. I could be incorrect. Um, but essentially consider pneumothorax. Traumatic, obviously, as well. All right, in terms of investigations, chest x-ray should show it. Treatment, small, stable patients, observe supplemental oxygen, those types of things. If it's larger, symptomatic, needle aspirate. So I think most commonly it's a second intercostal space, mid-clavicular. However, personally, I've kind of seen mostly in the Alfred, they go for the fourth or fifth intercostal space. I think they've kind of just got the resources and all that for it. And if it's larger, which most of the cases are in the Alfred, it's more commonly done there. Anyways, complications is a tension pneumothorax. So if you have an individual with all the signs and symptoms of a pneumothorax and they are also cardiovascularly compromised, you need to immediately kind of decompress them and like ambos will do it like on the scene and everything like that if needed, if it's like very much desperate, because it can kill a patient. Anyways, that's a wrap. That's everything. Hopefully that was a nice run through. I think do read up on your meds for like asthma and COPD, like the specific names that you know, each of the types of them. And yeah, if you have any questions, send them through. Welcome to answer. I'm happy to answer them. And good luck for exams. All the best, guys.